Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to another episode of the American Academy of Orthopaedic Manual Physical Therapists. This is Tony Varela. I have the pleasure of talking to Dr. Ney Meziat from Brazil. He is in Rio de Janeiro. He is a physical therapist who's been practicing for 24 years. He has a Master's of Science in Collective Health with a major in epidemiology from Universidade do Estado do Rio de Janeiro, the Institute of Social Medicine. He also has a PhD in collective health, also majoring in epidemiology from the same university, and he works as an assistant professor in the Centro Universitario Augusto Mota, also in Rio de Janeiro, where he supervises and mentors master's and doctoral students, teaching the disciplines of epidemiology and clinical trials. He's also a self-employed physical therapist working on patients, assessing and treating them for musculoskeletal pain in private practice. He does the professorial work and physical therapy work both on part-time basis. As part of his research, he focuses on cognitive functional therapy, and today we are going to be talking about his manuscript, The Effectiveness of Cognitive Functional Therapy versus Core Exercises in Manual Therapy in Patients with Chronic Low Back Pain After Spinal Surgery, a randomized controlled trial that was just published in the Physical Therapy and Rehabilitation Journal. He has several manuscripts investigating the effectiveness of cognitive functional therapy, and he is currently working on additional randomized controlled trials investigating the effectiveness of cognitive functional therapy for chronic low back pain. So I have the pleasure of talking with Ney Meziat. Welcome to the show.
Thank you very much, Tony, for having invited me to this podcast. It's a pleasure to talk to you.
I'm very excited about this conversation. The idea of incorporating the psychosocial and spiritual model into patient care is very intriguing to me, and I have found it to be very effective with my patients who are dealing with chronic back and neck pain and chronic pain altogether. However, I'm not trained in cognitive functional therapy, so I would like to discuss your manuscript, of course, but the idea of cognitive functional therapy more so. We know that cognitive functional therapy is the integration of foundational behavioral psychology and neuroscience that is directed toward addressing the link between cognitive and emotional factors, as well as the biological factors associated with one's pain experience. So, Ney, can you expand on the definition of and the application of cognitive functional therapy for us?
Sure. I would add that CFT is an integrated and flexible behavioral intervention delivered by physiotherapists directed at the multidimensional biopsychosocial nature of chronic low back pain. Actually, initially of chronic low back pain, but I think we can say that chronic musculoskeletal pain in general, especially non-specific primary chronic pain. There were three main components in the intervention. The first is making sense of pain, which is a reflective process that uses patients' own story and relevant life events combined with their experiences during behavioral exposure to not only reach a new understanding of their pain, but also increase self-efficacy to accomplish their goals. The second is exposure with control, which is a process of behavior change that enables individuals to gradually return to their valued functional activities without escalation of pain and the distress associated with this. And the third is lifestyle change, which is to help patients embrace a healthy lifestyle. Strategies for altering unfavorable lifestyle behaviors are discussed as part of making sense of pain. So these three main components are complemented by a fourth component, management of flare-ups that can happen. So we know that chronic low back pain, even when the patient achieves a very low level of pain and disability, it is very common to flare. So we have this fourth component, which is considered new, but is to try to help the patients in the long term.
I'm interpreting that, Nay, as ensuring that the patient and client that you serve gains self-efficacy with the management of their own dysfunctions and pain.
Yes, exactly.
It also seems that CFT works to adapt to the individual's profile that includes making sense of their pain, like you just said, and exposure control and lifestyle change.
Yes.
One way I interpret that is that it offers a mechanism for the patient and client to find a sense of coherence with their overall quality of life. And it seems like they gain a sense of meaningfulness and a sense of purpose. Do these ideas resonate with you?
I think this your interpretation is correct when you mention meaningfulness and sense of purpose. But since we are talking about chronic non-specific or primary low back pain, one challenge is helping a patient to make sense of the biopsychosocial reasons why he or she has become chronic. It's much easier to blame the structure of the spine by saying your disc is degenerate. For most patients, it's necessary to reframe what chronic pain is, considering the individual context of their lives. That's why patient-centered treatment that we improve, we enhance the therapeutic alliance is so necessary.
And through that improvement, you're addressing the quality of life that I'm certain then becomes something that builds confidence and self efficacy.
Yeah, we use the patient-specific functional scale for establish the functional goals of the patient because it's a scale that provides results based on their preference, considering the activities that the patient wants to recover. Unfortunately, we haven't included a questionnaire about quality of life. Actually, one trial that we are performing included a questionnaire to assess quality of life. But I think that improving the biopsychosocial multidimensional approach, we have more chance to improve quality of life. I agree. And since it's focused on patients' values, we decide the objective of the treatment together with the patient. It's a patient-centered behavioral approach.
Yeah, I appreciate that. It seems inherent that quality of life would improve if you're addressing what I'm going to consider and say as the mind body connection in the biopsychosocial model. And I did notice within this particular study that you did not follow up on the perceptions of quality of life. And you also did include an assessment of how self-efficacy changed. Can you share why self-efficacy was not assessed or researched as a part of the secondary outcomes to this particular study?
Yes, self-efficacy seems to be a mediator between CFT approach and disability reduction. It explains disability reduction in the reason why we haven't used the self-efficacy questionnaire in our first three studies was that we focused on having a very short follow-up questionnaire with the aim of decreasing the chance of lost follow-up of participants because the first two trials, CFT clinical trial, had very high loss of follow-up of participants. So we had to make a decision because we are gonna have to call patients to respond to the follow-up, and this call should not take so long. So that's why we decided not to include self-efficacy. But I agree that's very important. We have a CFT placebo-controlled trial. The paper of this study is in preparation. In this study, we collected data on self-efficacy, which I think is very important. It's one of the factors that explains why safety reduces disability, in my opinion.
I agree. I'm very happy to hear you say that self-efficacy is a mediator in the overall outcome between cognitive functional therapy, CFT, and chronic low back pain. I guess what I'm saying is I feel strongly about self-efficacy as a mediator in most of our outcomes. So I'm glad that it's been researched before, which I understood, and that you're including it in your upcoming research. Getting back to CFT, can you highlight the specific underlying interventions associated with CFT? I'm thinking of them as examples of acceptance and commitment therapy, which is ACT, or cognitive behavioral therapy, which is CBT, mindfulness and meditation, and or dialectic therapy. Are any of those treatment options incorporated into cognitive functional therapy?
Great question. I was thinking about the conversation with Peter O'Sullivan. I try to remember if we talked about that. But in my opinion, not only ACT, CBT, motivational interview, and mindfulness, but also the physical dimension, Salmon's, Mackenzie's spinal segmental stabilization systems have influenced Peter O'Sullivan when he created CFT. But the way these interventional approaches, maladaptive functional behaviors, is unique. So I think that all these approaches I just mentioned, there are some concepts that are very valid and others are not so valid, not important. Sometimes the available evidence, we have to use part of that system. I think Peter O'Sullivan was able to summarize what is important and put it together in CFT. So pain neuroscience education as well is part of that, but CFT is not pain education, it's different. It considers much more enhancement of therapeutic alliance based on patient history than trying to teach patients about pain. Sometimes teach patient about pain, but in the context of patient's story. I think that maybe there are more interventions that I don't know if have influenced him.
You are highlighting the importance of movement and function and the associated maladaptive behaviors to cognitive approaches that become meaningful for the patient, and that you're finding a way to bridge the bioanatomical or biomedical circumstance with the psychosocial situations and circumstance specific to that patient. In other words, you're making the movement meaningful to the patient.
Exactly. I think CFT provides the physiotherapist an approach that is able to create an interaction between, as you said, the mind and body in a way that movement is a behavior. We analyze movement and posture much more as a behavior. After it's a response like pain, the behavior change after pain. Try to understand, observing the way patient moves and their facial expressions, if their muscles are guarding. So this interaction between cognitive, emotional, and physical factors is something that is very unique. There are many interventions like pain education that combined with other interventions. CFT is the whole package.
I love what you said about movement as behavior. That's really what it comes down to. And I imagine it becomes very educational for the patient to experience, where they get to understand themselves to a different degree. With that being said, can you recommend an actionable take-home message from your definition and application of CFT and the research for CFT that would be meaningful to the psychologically informed physical therapist that is not fully trained in foundational behavioral psychology? I did hear you mention therapeutic alliance a couple of times, and it seems like that might be an initial stepping stone to truly understand and enhance within physical therapy. But is there anything else that you might recommend as an actionable take-home message?
First, I am convinced that we are not trying to be psychologists, because sometimes physiotherapists say that you are doing something that is not for your area. So I think it's not true. Yeah, I have been talking with some psychologists about what I am doing in my office with my patients, and they agree that no, it's not for me. I think it's much more for a physiotherapist than a psychologist. Although we know that both psychologists and physiotherapists treat patients with chronic low back pain, and sometimes treating together is a very good, very positive, and very motivative interaction. I think we are just understanding that provoking movements and postures of people with chronic low back pain are part of a maladaptive functional behavior that is directly influenced by beliefs. For example, pain is the same of damage and emotions. For example, fear of movement, that's very common and neglected. Therefore, it's very important to start to open our eyes for these aspects in physiotherapy. So when we start to see these behaviors in front of us in our patients, and we start to use these techniques to enhance therapeutic alliance and to motivate patients to change their behaviors, we start to enjoy physiotherapy much more, in my opinion.
It sounds like the work that you do in training the physical therapists to help with the treatments in your study, that they also find their enhanced skill level by learning cognitive functional therapy techniques, that they begin to enjoy more so their discipline and their engagement with and service to those people with chronic pain, and in particular those with neck and low back pain.
Definitely. And these physical therapists that attended the training for the clinical trials, I think most of them or all of them are continuing using the CFT in their work as a physical therapist because they think this intervention is not only good for patients, but also for the therapists. I think it's making sense is something that is not for the patients, but also for the physiotherapist as a healthcare professional, and to think that we are making a difference in the patient's life.
And I imagine that the therapeutic alliance goes both ways here, where the physical therapist or physiotherapist gets to truly understand the inner workings of the people they serve, and the interventions provided become very meaningful to the individual being served, which makes a difference in the outcome. I guess now would be a good time to identify that this particular study that we are discussing demonstrated that CFT was more effective than interventions providing core exercises and manual therapy, and that those interventions had significant effect sizes. I do have a question, though, about the psychosocial factors with the participants in the study. Most of the participants in the study were experiencing the full spectrum of psychological factors, which included stress, anxiety, fear, catastrophizing, and depression. And I certainly understand that we can recognize the overlap between all of those psychological factors, but yet I'm also compelled to identify that each can present in their own way. Did the physical therapist ever attempt to granulate the specific factors relative to the participants? Did you find that some therapists had to focus on anxiety more so than depression, or some therapists had to focus on the dimensions of catastrophizing versus fear?
Given that CFT is an individualized patient-centered intervention, it was expected that the CFT treating physical therapist adapted to the characteristics of each patient. The physical therapist could have identified not only by questionnaires, but mainly during the interview and exposure, that a patient presents high levels of anxiety, fear of movement, and catastrophize, for example. And when this patient is being exposed to the most feared functional task, it's expected that the physical therapist spends more time in the preparation for the exposure. For example, using mindfulness to relax abdominal and spinal muscles. We can use emotional regulation techniques as well if you see that the level of fear of pain is very high. So I think CFT provides options for the different types of patients. As you asked, we use the questionnaire, but most of the time, if we perform a good interview, we are going to realize how the questionnaires are superficial, and that it's very important to listen to patient's story using techniques like mirroring, reflecting patient's emotions, and using techniques like summarizing what the patient has already spoken. And so I think this is a way of enhancing the relationship between the patient and the physical therapist. When we go to the exposure with control, we are going to have much more chance to succeed than with don't have an enhanced therapeutic alliance.
Well said. Getting back to that therapeutic alliance, I read in your manuscript that strong and sensitive communication skills, observational skills, and clinical reasoning skills are required for the full application of CFT. These skills are essentially categorized as soft skills, and they can be incorporated with manual therapy skills and physical functional activities. Can you share your thoughts as to how a PT can use physical activity to help the patient mobilize a mindful approach towards movement, and I'll use your term now, towards functional adaptive behaviors that allow for energy efficiency and pain modulation and control?
These soft skills you mentioned are mandatory to succeed when using CFT. I don't know in the US, but in Brazil, unfortunately, I think we don't have that included in the graduation course of physiotherapy, but I think we should. In CFT, physical activity will be used in two different ways. The first will be to change the maladaptive functional behavior that generally is associated with different levels of fear of movement, catastrophizing, or hypervigilance. These maladaptive behaviors can be classified into control impairments and movement impairments. So it's difficult to find that. You are going to find that in some few papers in the literature, but it is very important to understand the difference between control impairments and movement impairments and the different types. It helps clinicians' clinical reasoning. In the control impairments, for example, there is no spine movement restriction, but a provoking movement or posture in one direction or multi-direction that are relieved when the movement is distributed to the hips and the thoracic spine, for example. It could be a flexion, control impairment, or an extension, or lateral shift or frontal plane control impairment. While movement impairments are movement restriction, the movement is reproduced in the direction of the restriction. Exposure to restricted lumbar movements improves movement and pain. So we retest and see that the movement is increasing and the pain is decreasing. So we are in the correct path. So in the second, this is the first specific exercise for patients to correct the maladaptive functional behavior. And the second is related to lifestyle change. We try to motivate patients to choose a physical activity that they were used to enjoy before pain. So we try to find the bright spot. The bright spot of physical activity is something that the patients were used to do and were happy when they were doing that. In the past, they were very confident on their bodies and that they had stopped doing, unfortunately, because of the pain. So we try to evoke the bright spot because it's much easier to recover something that you were able to do in the past and you liked it, you enjoyed, you spending time doing that activity, than trying to find a new one. So I think most of the times patients have a bright spot and we try to understand and to identify the bright spot in patient's history and motivation. We try to use that as a motivator for the patient.
Absolutely. That movement and function that's important to them and has been disrupted because of the pain they've experienced must be something that you address through the exposure with control. But now let me ask you another perspective of exposure with control. Do you ever move into emotional exposure or social exposure with control, addressing the totality of the biopsychosocial model as well as their underlying disability?
The exposure with control is adapted to what the patient determines as a goal. From lifting a weight from the floor to traveling or going to the beach with friends or to go visit relative in a very emotional context. I think all these circumstances and situations can be used as a challenge for the patient if it's important for the patient. Sometimes the trigger is emotional. I agree that we have to expose the patient to this emotion context in a controlled way. An important aspect. We don't focus not only on physical aspects of the exposure with control.
Well, thank you for sharing that idea. I know it's a sensitive one, whereas some physical therapists might think that is beyond the realm of our discipline. But like you said, I would imagine it's almost impossible to get away from when the activity, the movement, the function is important and valuable to them and has been something that essentially was lost and now they are regaining slowly. So it seems like there's a lot of power and effectiveness with cognitive functional therapy. I think the study that we're referring to, just published in PTJ, is a beautiful study. So I think it speaks volumes of how cognitive functional therapy is gaining traction and momentum and is going to make a big difference. Because like you said, it's the package as opposed to isolated intervention that's combined with other interventions. This one seems to encompass the totality of what's necessary to truly address the biopsychosocial model, which now I find myself incorporating spirituality with that. But I imagine that's beyond this conversation right now. But speaking of all of this and seeing how far you've come as a physical therapist and as a researcher, can you spend a little time describing your own journey with CFT and how it has influenced you and contributed to your evolution as a person and a physical therapist?
In 2014, I had just finished my PhD when I decided to go to London for the CFT workshop with Peter O'Sullivan. Before that, I had already written my first case report about CFT. This paper is published in the Old Manual Therapy Journal. That time I thought I was able to treat a patient applying the knowledge I learned just from the papers of Peter O'Sullivan's group, and it violated my expectations because I started to open my mind. And I thought, if I go to the workshop in London, maybe I'm gonna improve my clinical reasoning and my effects I have with my patient with this kind of approach much more. I was right. After the workshop, my clinical practice changed substantially, and I decided to go to London for a second workshop in 2015. Meanwhile, I started as a postdoctoral researcher at Muniswan, and along with my PhD students, I started to write my first project of a randomized controlled trial to investigate the effectiveness of cognitive functional therapy versus manual therapy and motor control exercise. And also, the second one was CFT versus core training in manual therapy. Since then, I have trained more than 5 treating physiotherapists for clinical trials, and I have been treating my patients with this intervention, thinking that we have something good. Of course, it's a kind of intervention that is based on biopsychosocial model, but the biopsychosocial model is not perfect. As you said, we can include other dimensions, but for this moment, we have to move to the biopsychosocial model, and we have to avoid the iatrogenic way of thinking and with over-diagnosis and over-treatment of the biomedical model that most of the times physiotherapy is based. So this is an opportunity to convince physiotherapists that there is something biopsychosocial model is treating patients based on biopsychosocial model is possible. You have this approach, so it's not difficult to understand and it's not over treatment. It helps patients to self-manage their pain and disability, which all the guidelines suggest. So I want to continue conducting these trials. We have some very interesting results to be published, and I hope to see that this kind of interventions and other interventions based on biopsychosocial models are implemented around the world to help people with chronic low back pain.
I hope so too, because it seems very promising based on the research that I've read. And I think the way that it's been developed and incorporated into patient care helps to bridge the interventions that seem to partially work when they are delivered in isolation, as with counseling, as an example, that is attempting to manage an individual's pain. So it seems like this is something that really allows the physical therapist to connect to their patient. Hopefully, it raises the emotional intelligence of the physical therapist, and I think the potential for it to really provide a actionable application of the biopsychosocial model for the patients we serve is going to be one of the main highlights of cognitive functional therapy. With that being said, Nay, do you have any other ideas or suggestions that you would like to share with the listening audience?
I am predicting now that it will be in all guidelines for chronic low back pain. I'm sure it will happen. But maybe if we consider the patients with chronic low back pain with low levels of disability, maybe we have many options to treat these patients. But very disabled chronic low back pain with high levels of psychosocial factors influencing the pain and disability, we are going to have to use this kind of intervention, this kind of approach. So in this paper of Leonardo Avila, who I supervised, I was his co-supervisor, he had this idea of doing a clinical trial for patients with chronic low back pain post spinal surgery. And he had this idea because he treated so many patients in this condition. I also treat this kind of patient a lot in my office. So we were able to see in this context with patients with higher levels of psychosocial factors, we can be very, very effective with a very high effect size. However, we are comparing CFT to other active exercise-based therapies. We have a small effect size, which I think, in my opinion, it could be not considered something that, let's forget about CFT to these patients. No, I don't think it's the case. But if we want to be more effective, we are going to have to treat patients with higher levels of disability and psychosocial factors. We have the results of RESTORE trial, which included patients with a certain level of disability. We have the results of Avila's trial, and we have two others that we conducted. One is published that the result was not so good, because if you see the baseline of these participants, you're going to realize that it's lower than the other trials. So I'd like to finish saying that I think this intervention will be recommended for patients with chronic disabling low back pain, especially the ones with higher levels of psychosocial factors. I think if we consider that most of these patients, very disabling patients, have high levels of psychosocial factors, we can just say that very disabling chronic low back pain CFTs will be recommended for that.
Awesome. You've made a believer out of me. Though I'd have to admit, it doesn't take much when you start talking about the biopsychosocial model and cognitive therapies, things of that nature. Nay, we're going to put some links into the podcast and the show notes for your manuscripts, specifically the one that we are reviewing and discussing. And then you mentioned your first manuscript in the Journal of Manual Therapy. Is there any other resources that you would like the readers to know?
Yeah, I have two papers that I think both are very good to understand what CFT is. One is another case report published in the Manual Therapy, which is about lower limb loading impairment. This paper has a supplemental material with videos about this patient, about the treatment. I think this is very interesting. I use that for my lessons. And the other is about CFT for chronic neck pain. It's a case report as well, published in Journal of Bodyworks. And there are some videos as well about this paper. And I think it's good to understand what CFT is. And the other trial published in Pain, I'm going to send you as well. Okay.
Excellent. Well, thank you very much for all of your time and sharing your knowledge and expertise with us. This has been a very enlightening conversation.
Thank you for having me. It was a pleasure to talk about this topic.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.